Good evening to everyone. Thank you very much for being here again. It's a pleasant surprise. Dr. Afzal Zavadi is here. What a wonderful thing. What a wonderful thing. Welcome you, sir. Right, I think this time we thought we will not have too much of a didactic presentation and take up the questions. That's what last time I said that, okay, we have done about 3 seminars, 3 webinars, something about the good prognosis of bipolar disorder, and then bipolar disorder 2 being the diagnostic validity of bipolar 2 being questioned. And lastly, some of the case series. I think I presented about 2-3 cases, and from that I thought that let's see that what are the questions which are going to come, and then let's first have an interactive session. So what I'll do today is that I do have a few slides for presentation. In between, maybe I'll go to that and then come back. But to start with, I'll now put up the questions here and then say that this session is very specifically for the question answers. Right. We thought that we'll have about 20 questions and then limit it to the only 20 questions. And then see that if we can manage 20 questions in that, that's going to be one fantastic thing. I saw these questions, and then I think I must really thank every one of you for the kind of enthusiasm and the kind of they're showing that what exactly is that, and so many questions are lined up. Maybe there are 1 or 2 slight repetitions, but very clearly, I think there are quite a few very challenging questions. I don't think I'll be able to answer all the questions also to your satisfaction, but I'll try to do what best I can do. There are a few. The last question, I think maybe some of you may not be seeing here, more on BD is good prognosis disorder and bipolar 2 disorder is a myth. That is what. The very first question here again, let me tell you. Now, when I'm doing that, maybe in between also some of you can ask questions. We have a chat box here, but I want all of you to read the question. So I'm going to leave this slide open for me for next 5 minutes so that every one of you can just run through the questions. This question by Dr. Easwaran from Pondicherry is a wonderful question. I think he hit me at the basic of what I was talking about. Last time I put a slide saying that mood stabilization is a faulty concept. He asked me straight, why should the concept of mood stabilization be considered faulty? And then the next 2 sentences of his are absolutely right. When that is the identified pathology, number 1, very definitely, that is the identified pathology. I keep talking every time that bipolar disorder, recovery is the rule, recurrence is the rule. When I say recurrence is the rule, that is the identified pathology he is talking about. And the goal of therapy is prevention of next episode, recurrence. Absolutely, there's no doubt. See, the natural course of the illness, there is recurrence. And then what we have to do is that the goal is that prevention. Then why do you say that it's a faulty? Sir, I think last time also I answered this. Number 1, I object to the term mood stabilization. I have no problem if you talk about prophylaxis. Prophylaxis is the term which is medically we all know, and it's got a specific meaning. Mood stabilization is very vaguely, it's been talked about all along, and I'm very happy. I think that also I put CanMat 2018 has categorically said that the definition of this is very vague and non-specific. So we are not going to use this term mood stabilization at all. They didn't use it. And then it's not a question of term, prophylaxis or something, but I think last time I was talking about, theoretically, it's fantastic. You have an illness where there is recurrence. Theoretically, you have to prevent the recurrence. Absolutely. There's no doubt about it. That's what, as a medical man, we should supposed to be doing that. But Are we able to do that? That's going to be the biggest question. Do we have the tools to do that? Do we have the kind of a medication, what, including lithium? Sir, you have given an example as a lithium. I completely understand that now, like, lithium is the gold standard even today, but last time I think I have raised a few issues even about lithium. Aripiprazole, yes, sir, theoretically it's a very good molecule, but like, I do not know how much it's going to be used as a mood stabilizer experience. And lurasidone, again, it's a very, very, like in a very early stage to talk about it. It's very, very difficult to talk about it. So theoretically, it's fantastic. But when it comes to the practical thing, are we able to deliver the goods to the patient? We don't seem to be. That is why I said that I even compared with one or two other examples also, saying that this is the problem. Maybe I'll again put up the slide. Right. Then there are other questions like how long a person should be on valproate, right? This is a very important question. What is the significance of contextual factors? Is it largely like genetic, biological, right? Mostly I consider this. And this is also, again, here I think this question is something which is very, very elaborate. Maybe sometime later we can take it up. And then irritability is like, how do I control this? Maybe I answer and come back to these questions. Maybe why BD2 is a myth. I think I have talked about it very, very clearly. Should we prescribe? I'll talk about it. I think maybe one or two slides I'll go to that and then come back. Maybe another reason is also there, maybe because once I put up these slides, I think I'm sure all of you must have now read these questions. I'll see whether there are any questions coming up here. Right, and then somebody said, am I audible to everybody? Somebody said it's not audible.
Sir, you're audible, sir.
Yes, yeah, right. Your view about schizoaffective disorders. Right, schizoaffective disorders, as of now, it's a kind of somewhere in between it comes. I don't think we can really use it as a valid diagnosis. It's very difficult. Maybe a small group of patients are there where sometimes we have difficulty in diagnosis. But I think otherwise, I don't diagnose schizoaffective because it doesn't really convey anything, and the diagnostic problems are there. And then because the mood affect and then mood stabilization, the thing, why is it that I am so much talking about it, saying that repeatedly? There seem to be a faulty concept. There seem to be if we don't seem to be having enough kind of a tools or medication. Let me show you maybe 2-3 slides, and then again maybe I'll come back to this. Yeah, before that, let me also say a few things like that. I have this habit of raising some questions. Now, I'll also introduce it. This may not be very relevant to the present thing, but now just a few of these things to let you know about my thought process and my kind of a thinking. Sometimes it happens. It's not only in bipolar disorder. This is something. Personality disorder. Personality disorder like OCPD, SSRI seems to be reasonably helpful. That's what. Now, this is something which I would like to share maybe less. And then this is what for a long time I was thinking about. Simple schizophrenia diagnosis. It's not a very correct thing for psychiatry to do that. Fortunately, DSM-4 itself, it has removed it, and now we don't talk about it. Yeah, absolutely, this is not with that. And then these are the two things also I was talking about for quite some time. And this is something which for a long time I said that there is nothing like negative symptoms. I'm sorry, I'm deviating completely from the bipolar disorder to some other topic. But let me just to say that negative symptoms in schizophrenia are always secondary. There is nothing like a primary negative symptom. This is what I talked about in a few of the meetings also. And we are now the problem here is that there is nothing like primary negative symptoms. We keep chasing and inventing drugs to control the negative, which is absolutely doesn't make any sense. This is where DSM-5 schizophrenia, I really salute the task force, because maybe now there's no time, I can't show this. Without delusions or hallucinations, you cannot make a diagnosis of schizophrenia according to DSM-5. Previously, DSM-4 is not like that. Out of 5, any 2, and the 2 need not be delusions, hallucinations, simple negative symptoms. So they're completely undermining the negative symptoms, like in the role of it, which are all very, very important. Yeah, anyway, this is again another thing. Oppositional defiant disorder. I'm sorry, I'm very, very sorry if I'm not like deviating that, but this is one diagnosis. Again, I have some real, I used to say that once in a while, there is something like oppositional DNB disorder. Whatever you say DNB students don't do, so you call it as opposition. What is this disorder? Because this disorder has been criticized by one neurologist in one of the meetings very, very badly. I had to get up and then sort of discuss with him, saying that why do you take up this particular thing? So ultimately, this is me. This is just given a 2 minutes of introduction about me. See, the reason, sir, I think Dr. Iswaran has asked me, why do you say it is faulty? Quickly, I'll run through this and I'll come back. Always my problem is this. This is my problem. This is the one thing which, and then this is again thing. Starting below the age of 25, a good prognosis. Somebody asked about it and I'll again come back. These are the very important points when I talk about bipolar disorder. Starting below the age of 25 years. Good prognosis disorders. And then we say that, no, they don't have functional recovery. And then euthymia for years without any intervention. This is something which we all have to agree and accept, saying that, because a lot of times I keep hearing people saying that, Dr. Reddy, we are treating. They're becoming all right. And what's the problem? No, this is because of this. We are losing an opportunity cost in overdiagnosis and over-treatment. I talked about it last time. This is the problem. This is again the problem. These are the issues. These are the issues. These are all the issues. This is why I keep coming back to you again and again, again and again. And lastly, I have added one more point today. A large proportion of non-bipolar depression is de facto neurotic in origin and is best treated with psychotherapy. This is none other than Dr. Nasir Ghemi. In that article, Antidepressants Are Not Antidepressants, in 2008, he makes this statement. So now do you see that? Do you get the point? On one side, we diagnose RDD as bipolar. Then acute phase of depression, we don't want to use because not used, under treatment. Long-term treatment, again, invariant use of mood stabilizer. This is something where all the side effects are coming up. You don't use this, again, the problem is suicide prevention. We do not know what is the suicide prevention capability of quetiapine, which is frequently used. And this is something which is coming up. Yeah, bipolar depression. This, I think if you remember, last time I did talk about something. I tried to compare CBT, also saying that it's fantastic in theory. But when it comes to the clinical practice, right, it's very, very disappointing. I almost said the disaster, same thing as mood stabilization. Because there is something about the therapy and psychosocial intervention, all those things, I'm just talking about today. Just today I saw in the web groups. Look at this, the voice of the American Psychiatric Association, psychiatric community. Look at this. This is what it is. Meta-analysis in JAMA says that psychosocial interventions can improve the function of the immune system. Wow, fantastic finding in the light of COVID pandemic. Looks very good. Meta-analysis showed that these improvements are most consistent for CBT and also for interventions up to this point. Not like why I specifically wanted to this point is that, like, sometimes this kind of a statement, there is some element of truth. Actually, somebody asked me, what is the role of yoga in the management of continuation or maintenance phase of bipolar disorder? By practicing yoga or meditation, can we, the maintenance therapy can be changed. It's like hypertension. You need medication first, but with relaxation and all things, maybe to a certain extent, drugs can be reduced. That's the only thing. I'll share. Psychosocial interventions on some measures of immune health. Most of the studies involved, this meta-analysis is mostly basing on the studies, psychosocial interventions in people with cancer or HIV. I'm stretching it a little bit too far here. I'm really stretching it a bit too far, but still saying that Psychosocial interventions, they are talking about in people with HIV. Sir, you and me know that today one of the great success stories in management of AIDS and HIV, there are two factors. Number one, antiviral therapy. Number two, preventive is, I'm sorry, I'm saying that, preventive is condoms. It's not psychosocial interventions. It's a condoms and then not like an antiviral therapy. But now psychosocial interventions, maybe to a certain extent, in the same way, I say that CBT or psychosocial intervention to a certain extent, but it's mainly the prophylactic drugs, which sometimes we are failing in that. And then same thing I showed you that this is a step BD. Look at the age of onset. I just wanted you to show this slide. Below the age of 14, 15 years, almost 60% of the patients. This is now like in stability study. This is the age group where there was onset of bipolar disorder. And now I'm coming back to you. At that age, even starting from third year or fourth year, you diagnose and then start on the so-called, whatever the now drugs you talk about, mood stabilization, the faulty concept going on for 5 decades, 6 decades. That is where the problem I am worried about. All right, I'm coming to the questions here, sir. In a patient, very well maintained lithium, but if serum creatinine starts raising, patient is diabetic, can't give SGA, get CPR with FGA and maintain only of lithium. Yes, sir. I think there was a question on about lithium. Dr. Iswaran also talked about. That was about lithium. I have one patient where I can say that definitely this lady, bipolar depression, I tried every possible thing, including antidepressants, including ECT, 1 or 2 patients where I gave ketamine therapy, did not work. She was doing very well on lithium, but creatinine slowly is rising. There, monitoring the creatinine levels, I restarted lithium and the patient is doing very well. But at the same time, I say that right now, she's going through a phase of mania. That is what my worry is about. We can give lithium, but I think we have to be extra careful, take the relatives into confidence, and then only we can talk about that. Otherwise, we cannot. Now, what I'll do is that before going to these questions here, role of SSRIs in bipolar depression, I do give, sir. I do give SSRI. That is what one of the main things I was talking about. Treatment modality in borderline personality, will come to it. We'll come to it. Let me, I was really talking about this particular thing. And then why I was so much worried about it, I'll just, I just want you to feel the gravity of situation in this overdiagnosis of BID and then underdiagnosis. And some of the questions you asked, like, maybe why do you say that bipolar 2 disorder is a myth? Now, why mood stabilizers are being underused or overused, and what is this prophylaxis? All those things. This is, I'm talking about 3 patients. Maybe, I don't know, 3 of our colleagues who have got a problem of simple depression, recurrent depressive disorder. I keep talking about bipolar disorder and all things fairly in most of the meetings, and then they wanted to have an opinion, and then they came to me. This is a diagnosis, colleague psychiatrist, RDD with OCPD, but it's previously diagnosed as bipolar disorder 2, or they themselves diagnosed as bipolar disorder 2. According to me, this is this. According to them, this is this. So a lot of times we have problems in the diagnosis. There's no problem at all. There's no issue at all. But the point is that look at the kind of next consequences of one after the other, which I've already talked about, and then let's see that. They refuse to take SSRIs because they know the literature is talking about, journals are talking about, textbooks are talking about. Whatever I talk about, it's not going to. What are the problem? Are they effective? I think some of you must have heard about it. Antidepressant associated chronic irritable dysphoria. They're worried about it. Then what about this? What about this? That's why they're now like in a kind of a confusion. Then the reason why initially also I told that faulty, this is a dictum. If this dictum is not there, maybe I may not be very critical about the now like this concept of mood stabilization, but very dictum of invariant use. And for how long? I think somebody asked the question, how long should be the mood stabilization? We did talk about in the previous two cases. I did talk about, my title of one of the topic is that why do you have to continue, or why did you continue for a decade, one episode of them? But we are all told that it's for life. That's where I think last time I gave the example. You have bipolar disorder, there are going to be recurrences, it's going to be future episodes. You start something which is prophylaxis, is not going to have the episodes. Fantastic theory, but doesn't seem to be happening. There is a problem. There is a problem. This is weird. This is the problem. That's what I'm facing. And also this is what, this as I told, that was CPD, OCD. And then there's a problem. They refuse to take any antidepressants. And then all these are very valid reasons if you go by the textbook. And what do we do? As I told, that it's not mood destabilization. It's a clinician who is getting destabilized. That's what the problem is happening. That is why the reason why I said that this kind of concept, this is what the smooth concept of mood stabilization in the long run, then prevention of recurrences. This is what I thought when I started bipolar clinic, Asha Bipolar Clinic. But now I don't know. As I keep telling that which pit or which, where I am in. That's it. And then I'll go back to the questions. Here, just now I told that bipolar depression, antidepressants seem to be effective, but a lot of times the therapy is not going right. But Dr. Reddy, patients are also improving. I see a lot of patients, they are improving. What is this you're talking about? They are not improving with the medication. Sir, here is one thing which I want to say, that there's a natural course of illness. This is an excellent slide which I took from the Lashmi Adam's book. Just compare this one particular asylum, compare the periods, 1875 to 1924. This is the data, right? Average length of hospital stay, 6 months. Here, bipolar mania or depression, they have to recover. There is no doubt about it, but they take a long time. But here, because of our intervention, it has come down to 1 month. This is the phenomenal benefit psychopharmacology has given. This is something which we are trying to, even without treatment, they do become better. And that's what a lot of times maybe we are attributing to that. But this is something which we are trying. This is something which is not like a little bit of surprising thing. During 100 years back, admissions were 80%. Now admissions are 20%. I do not know, sir. It's only my guess saying that we are treating mania very effectively. My guess, I don't know. Admission for depression, 20%, now 50%. Again, my guess is that we are not, you saw one of my sets, under treatment of depressive disorder. Maybe we are not treating it effectively. That could be the reason. Right. All right. After this, I'll go back to the question. This is one of my very favorite slide, Thomas Insel's. He was an NMH director. See, in the last about 20 years, 30 years, all the physical illnesses, what is the kind of, how the morbidity has come down. This is a beautiful slide. This is a copied from his, in one of his presentations. 65 to 95, which are I think 5 or 6 years back or some time back, it was a slide presented. Leukemia, the morbidity has come down significantly in the last 30 years. Cardiac, significant. AIDS, we just were talking about. Stroke, we're talking about. Significantly reduction in the mortality. But when it comes to suicide, as a student, I was taught 15% of patients with mood disorders commit suicide. Now also I teach my students 15% of mood disorders, patients with mood disorders commit suicide. What are we doing? I don't say that there's no progress or there's no in psychiatry, there's a lot of this thing, but these are the facts which are staring at us, which we all have to have a relook at it. And then here, I'll go back to the, I think I'll go back to the slides. First, let me run through the questions. And after that, I'll come back to these ones. There are almost about, as I told, the 20 questions were there. And then I think we were answering only the first one or two questions, and then other questions maybe. But only problem is that when I am answering this, let me see. Right, because when I am seeing this, I don't see questions coming from the audience right now when I put this slide. So I think maybe here I did talk about aripiprazole, though considered, but not like how much. Lurasidone, if you ask me, sir, to tell you frankly, when the when the molecule was being introduced, some of these are my personal views. I was really looking forward to that because there's a big vacuum in the management of bipolar depression. So a molecule like this is coming up. Every one of us were now waiting for that, but I'm not all that happy with that. I cannot say confidently after 3 years of that, okay, this is a molecule. When somebody has got bipolar depression, I can give this, and then it does work very effectively. I can only say that I do use it, but very, very minimally. But like natural course of illness, maybe some of these patients are improving. That's the only thing I can talk about. All right. Is there any way, Chintan, I can see the questions on the right side? Now with this thing, I'm not able to see the questions on the right side, but anyway, I'll go ahead. How long a person is to take prophylactic medicine, valproate, if he is on valproate? Right, let me, I think it is, on the right side, is there any way we can, all right. Are the questions seen by everybody now?
Yes, sir.
Okay, right. Here, let me see that. How long a person to take prophylactic medicine, valproate, if he is on valproate since the age of 23 years age, and now 52, with history of taking novel antipsychotics and antidepressants intermittently, now only on valproate for the last 4 months. Sir, here I think I need a lot of details, because I think maybe next few sessions I'm going to present one of the cases where I kept valproate for almost 10 years for some patient. At the end of it, I had to question my diagnosis. Rapid cycling, you said, sir. Diagnosis of rapid cycling is a very, very difficult thing, unless it's very tightly switched from mania to depression, because previously, if you look at the remission, sustained remission for 8 weeks or 12 weeks recovery, it's very, very difficult to diagnose. And rapid cycling is one concept which is never a very steady concept all through the life of the patient. It keeps changing. Prophylactic medication, valproate, from the age of 23, you said that. But again, in between, he has been taking antipsychotics, antidepressants. I do not know how effective valproate was in this patient in the prevention of, that's what I told, in the prophylaxis of episodes. But he is only on valproate for the last 4 months. The patient is 52. It all depends on how effective that was. Otherwise, we cannot say anything about it. And here, what is the, right, I think this is a very good question. What is the significance of contextual factors and subjectivity in determining the prognosis? Is it largely genetic or otherwise biological? I think it's largely biological, or what it is. Contextual factors are important, but I think last time also I was showing that in case of a bipolar disorder, it's biological. Mostly, Freud was able to explain the depression etiological factors so very clearly, but when it came to mania, he was not able to. So it's not the contextual factors or subjectivity. It's a very largely, if not everything, I say that it's a biological factors when there is especially mania precipitation. But when it comes to depression, I think last time somebody put it very nicely. Post mania, a dysphoric mood, sometimes we may mistake as depression, and sometimes we may treat it. So in that may be different. Another thing I all say that we all talk about drug-induced switch to mania. But I repeatedly talk about drug-induced switch to depression, especially, of course, we are not giving haloperidol these days, but risperidone can produce drug-induced depression. I think the last time the patient whom I talked about, I stopped risperidone, the depression got relieved. That's how it is. Academic psychiatry responsible for underdiagnosis of bipolar spectrum and reluctant use of mood stabilizers. That Sachin, I really, academic psychiatry, if you ask me, it's actually academic psychiatry, which is actually a section of academic psychiatry, which is pushing the concept of bipolar spectrum. I think bipolar spectrum disorder, when there is no episode of mania, more than 2-3 episodes of recurrent depressions, and then some tolerance, atypical features and psychotic features, and then some maybe the family history where it is. I think last time I did mention about it. Number one, like bipolar 2, we have to be extremely careful in the diagnosis of bipolar spectrum disorder. So let us look at it from different point. Bipolar disorder is a pure mood disorder. Episodes of depression, fine. Episodes of mania with grandiosity, elation, absolutely no problem. That's a pure illness. If you include irritability, it's spreading. I understand why the people included irritability as one of the criteria, because the problem is that whether we are missing some of the bipolar disorders, where the manifestation is only irritability, and we are not diagnosing them, and thereby not. But now it seems to be reverse. We are over-diagnosing bipolar disorder. We are definitely over-diagnosing bipolar disorder. And then once we over-diagnose bipolar disorder, I think I talked about 1, 2, 3, 4, 5. No, invariably start on so-called mood stabilizers from day one. And how long? I think I just now talked about lifelong. We all talk about 4 years, 5 years. Sir, no textbook, nothing gives us 2 years, 3 years. It's supposedly for lifelong. It makes sense. Dr. Ishwaran told that theoretically it makes some sense. And no antidepressants. What about the suicidal risk? All the problems are there. Sensitivity we are trying to deal with, but specificity, I don't know to what extent we are able to manage with that. So I want people to be, if you ask me, I am basically a little bit, not just not in favor, against the concept of bipolar spectrum disorder. Because I think somebody asked me that just now, schizoaffective. I had a very good slide. Maybe next time I'll show you. What is the hurry? Let's wait. Let there be a clear-cut manic episode. Oh, come on. You want to wait till they have a manic episode and then treat it? Yes, sir. If it is acute treatment, okay, treat it immediately. So long term, I am looking at 20, 30, 40 years of medication. Then I better wait till I get a diagnostic, whether it's a biomarker or a diagnostic confirmation test. I will wait before I start on any long-term treatment. Definitely, sir, we have to. So that is why the spectrum disorder, I'm a little bit now like, you know, suppose you want, so let's see that. Suppose you had theoretically, you are seeing a patient, recurrent depressive disorder, 4th episode, psychotic, some of the atypical symptoms are there. There is now like in a family history of bipolar disorder. This is something which comes as a bipolar spectrum. If the patient comes to me, I'll still give him combination of antidepressant, antipsychotic, and see how he responds. But suppose the patient is not responding to your protein therapy, you are absolutely right in considering starting, I tell lithium. I'm not talking about any other drugs. I'm talking about lithium. Give it a try. You can take it as an augmenting agent, or you take it as a bipolar spectrum disorder. But then the question is, sir, after the patient improves, suppose the 4th episode, we're talking about 4th episode, bipolar spectrum disorder, no episode of mania, you started an antidepressant, antipsychotic, not much of a response, you added lithium, patient recovered. Excellent. Diagnosis of bipolar spectrum is there very much. on your data sheet. But if you ask me, at the end of 9 months, I'll stop all the drugs. Yes, there will be a question then. Fourth episode of depression, recurrent depression. So why do you want to stop? Still, I'll give it a try, sir. I'm not that great fan of antidepressant prophylaxis and prevention of future episodes also. I'll give it a try. And then suppose next 2-3 years, if he's all right, fine. Suppose he develops a mania, please go ahead. Make a diagnosis of bipolar disorder and go lithium, whatever the drugs you want to do. So that's where. I am not against prophylaxis. I am not against concept of prophylaxis. There are only two things I am against. Prophylaxis for decades. We have a responsibility to be responsible in starting that drug to the patient. Second thing is how effective this is. I have big queries. I talked about, show me one drug which effectively prevents postpartum recurrence of mood disorder. I don't find. So we have a lot of question marks there. Of course, Dr. Eastman also commented, there is no ideal drug. Something may come future. When it comes future, I'll take it up, sir. But no, I don't want to keep the patient right now for 20 years without a valid database of effective prophylaxis. That is what is. Right. Maybe some of these things I'll also take it like long-term problems with use of antidepressants. And borderline personality disorder, female with profound suicidal intent, treatment of it, sir, we'll take it later. That's nothing to do with that. Long-term problems with use of antidepressants. I think this will become relevant here because we use antidepressants, SSRIs, say citalopram, very liberally when we make a diagnosis of MDD, RDD, psychotic depression, along with melancholy. But the moment the diagnosis becomes bipolar, we say hold, rather stop, rather no. Somebody says that no, because I think I showed in my slide. Is it effective? What is the switch? Cycle acceleration, cardiac acid, all those things. But I find possibility is there. I think I've shown some slide recently also. At the 20 years follow-up, the switch or conversion from unipolar to bipolar is only 8%, even in those patients. I can show the slide again next time. It's a follow-up almost about 20 years, 90,000 patients is one study, 40,000 patients is one study. Unipolar depressive disorder, recurrent depressive disorder with psychosis, with inpatient, at the end of 15 years, the switch is only 8%. Otherwise, one of my favorite thing in talking about antidepressants is that, sir, I give escitalopram. I know, I think last time also I talked about sexual side effects and then those hyponatremias, which are very bleeding and all. 25 years, it's a fairly safe drug. Bipolar is it, I don't want to use it for 20 years. I use it effectively. The problem is antidepressants are not effective in management of bipolar depression. I think the topic has come. I think it's going to come. It's a very, very important issue. This is one of the recent things. There's a lot of controversy. I think unfortunately, the most controversial thing as on today in psychiatry is management of acute bipolar depression. And then we are lost. And both the sides equally, there are arguments and the counter arguments. Number one, the whole process started with STEP BD. Maybe initially there was some. STEP BD, one of the largest naturalistic study, about 5,000 patients. Gary Sachs was the principal investigator. They used 2 antidepressants and then compared with the mood stabilizer. And they said that antidepressants are not doing anything, nothing better than the other drugs, which are so-called mood stabilizers. The 2 antidepressants they used were bupropion and then paroxetine. I always use the question, why do you have to use bupropion, and then comment on that. That is one. Second thing is, of course, there is a group, even CanMat says that you can use, you can use, so no, sir. If you look at CanMat 2018, management of acute bipolar depression, it's in the second, not in the first line. Second. Number one, first line is all your lurazidones, quetiapines and all those things. Then second, then immediately the caution. Use minimum optimal dose. Who knows what is minimum optimal dose? Theory, it's very easy to write. What is the minimum optimal dose for this patient? How do I know? Number one. Number two, for the minimum optimal period. So I start with trembling 5 milligrams. With some trembling, I increase it to 10 milligrams. And then trembling always, because there's going to be a switch. And the moment the patient is all right with trembling, I'll stop it. How do you expect the bipolar depression to improve with bipolar antidepressant? That's what my question is. That is where it stands. Yeah, right. Maybe some other questions we'll take and then go back to the previous one also. Which combination of antidepressants and antipsychotic do you prefer as a first line? If it is like in psychotic depression, my preference is that olanzapine and then escitalopram. Escitalopram, for all the depressions I use escitalopram. Please excuse me for my bias. Olanzapine, okay, I know that there's a little bit of weight gain, metabolism problem, but I still use it. I have a patient with depression. Next episode was hypomania, presented with moderate to severe depression. I have started antidepressant. Is it safe to start under the cover of mood stabilizer? Dr. Sunita, I think you're asking a wrong person. The diagnosis. For me, hypomania does not exist. You may not like the answer, but for me, hypomania does not exist. I have shown today I have shown very clearly one slide. The so-called symptoms which are described in hypomania are dangerously close to normal variations in the behavior, and it's very, very illogical to call it as hypomania. These are not my words, these are Jin Mali's words. Schizoaffective, I don't know much. The less I talk about it, where will you place escitalopram, sir, for acute episode of bipolar depression? Number one, you give lithium or don't give lithium, whatever it is. We have done a study. One of our postgraduate dissertation is on, right, you may be surprised. 2 groups. One group was only on escitalopram, one group was only on lithium. People said that, how does the ethics committee give approval? We did. Both showed similar kind of like an improvement. Then I see a lot of other studies also that which antidepressant has less bipolar switch property. Here again, let me. You want an antidepressant which is effective. An effective antidepressant can produce a switch. An antidepressant which is least effective does not produce a switch. I think, sir, tinaptine, something like that. You can, but it does not have switch, because I feel that it doesn't even work. It's something like that. To check for switchover so that antidepressants can be stopped. Antidepressants, always you treat the depression effectively and then you stop it. Rapid cycling bipolar and a switch is a big problem. I do not really, you can start the patient on lithium. Why are you so worried about some rapid cycling and then switch? You have an effective gold standard prophylactic drug in lithium. Use it. Prevent manias and hypomanias. And what's the problem? Absolutely, you can do that. But then, are they effective? That is what the problem all the time I'm talking about. And that is exactly, I think it's unfair that we have to go back to the questions for some of the people asked. And then there is another next question is that, right, this is an interesting question, but I think this we have to really look into this. This is a patient, 40-year-old, previously well stabilized with carbamazepine. I don't know, sir. Nowadays I'm not using much of this. Rapid cycling, and then patient has been modified ECT. And he says that combination of valproate 400 milligrams and lithium 600 milligrams, there is some reaction. I'm not able to understand what is the toxic effect. And then lithium 600 milligrams, I would like to know what is the blood level, serum levels. Currently being maintained on clozapine, oxcarbazepine, and weekly maintenance ECT. This combination oxcarbazepine doesn't have much evidence. And then maintenance ECT for prophylaxis of bipolar disorder, again, I say that, but again, I understand this is not one of the, like a routine cases. This is one patient, well stabilized on one drug, then rapid cycling, then multiple episodes. I can understand your dilemmas, because I go through these dilemmas so much. I would say that try lithium. In spite of my queries about lithium, I still say that try lithium, maybe adjust the dosage. 600, I don't know what is the body build and all that. I feel that it's slightly on the low side. Keep it around 800,000. Go for the serum levels and then see whether that can be controlled. Lithium is the gold standard because we did talk about the very first question. Lithium is an example. And then right here again on lithium, there are other things. Let me say, sir. I some time back as an editor, we wrote an editorial, but for lithium, other mood stabilizers do not seem to be doing the job what they are supposed to be. So I think lithium, one thing we have to be dependent on, we have to be, like can use it. But lithium, again, maybe we can, last time also I did, like briefly ran through some of the slides in lithium. All right, we can talk about it maybe sometime later. How do you control mania patient with high irritability not controlled by medication? So there are a lot of questions will come here. Number one, high irritability. Number one, is it mania? I'm sorry. I'm very, very sorry to ask that question. Is it mania or is it, one of these days we'll talk about affective instability. Irritability can be a symptom of borderline personality, DMDD, OCPD. So is it that? If it is that, medication means what medication you are giving, that we do not know. Generally, one of the tendencies is that the so-called emotional discontrol syndrome, people are giving lots of anti-epileptic drugs like valproate, carbamazepine and all things. I don't think at present either we have an evidence or they are very, it depends on what is the diagnosis it's going to be. Why is BD2 a myth, sir? I did talk about it, sir. Because just now once I told, maybe I don't get tired of repeating it again. Bipolar 2 disorder is hypomania plus MDD. I think I told 1,000 episodes of hypomania cannot make bipolar 2. You have to have a major depressive disorder. Hypomania, I did ask question. Why is this hypomania? Why is there no hyposchizophrenia? Why is there no hypodepression? Why is there no hypodementia? Why is only for mania they call it hypo? For a long time, I was looking at, if you look at some of the long-term studies, bipolar 2, Judge, angst, long-term for years. What they see is that in the long-term picture, in the history of long-term history of bipolar 2 disorder, patients are asymptomatic 50% of the time. The depression is almost about 40%. Hypomania is 1%. That's hypo. And when people talk about subsyndromal hypomania, I get lost. I don't know what they're talking about. And then clearly the diagnostic criteria says it does not create any significant disability to the patient. So keeping all those things, see, right, why can't we just call it as a mild mania and then put it as a simple bipolar? Sir, do you believe in bipolar 2, 3, 4, 5, 3.5, 5, 6 and all those things? I think Aki's calls, there are a lot of classifications. 3, 3.5, do you believe that? If you don't believe that, why do you have to give so much of weight to bipolar 2? It's like that. No. Here again, let me say that. It's diagnostic. We have a lot of concepts. Sometimes it keeps changing, like as I told, that simple schizophrenia was there and it's gone. And then pseudoneurotic schizophrenia was there and it's gone. And schizophrenia, there are 4 subtypes. And it's not. Here, the major danger I see is that a patient with recurrent depressive disorder with a brief 2 days or 3 days feelings of slight, like feeling happy and a little bit more elated, get diagnosed as bipolar, and then the immediate dictums I am worried about. Invariant use of mood stabilizer, how long, lifelong, and don't use antidepressants, and then his depression skip. The treatment is getting into a disastrous thing. That is why the strong words are used. saying that it's a myth. I think I did send a note also when I titled this topic, saying that I know that it's rather a rash statement. The rashness is not out of arrogance or something like that. It is saying that how people are being misdiagnosed and then mistreated. I just now gave an example of 2, 3 of our colleagues who are nothing but, according to me, recurrent episode disorder, personality issues and all. They themselves diagnosed them as bipolar 2. And they're like, treatment is getting into like total disarray. That is the reason, sir, nothing else. Should we prescribe mood stabilizer considering soft bipolar? No, sir. For me, there's nothing like soft. For me, only one bipolar, sir. There's bipolar 1, and that too, elated, grandiose should be there, spending and all things, but irritability by itself, I think I've shown you some slide before. About 6 years back, there were 3 wishes for me, like Jenny. Number 1, throw out mood stabilization. It's been thrown out. Please bury bipolar 2. It's being buried now. At least now, like, some of the, I was talking and some of the now, like in the stalwarts, and they're talking. Third is that please get this irritability criteria out of diagnostic criteria of DSM-5. Please, you're going to do now like such a huge service to patients. That is one thing which is creating a problem. If we have time, if we all have time, I'm going to run through a pediatric childhood bipolar disorder where this irritability, what are we doing? I showed you step BD, the age group, starting from the age of 2, bipolar disorder diagnosis being made. Pediatricians are very angry with us, saying, what are you people doing? Age of 3, you're making diagnosis of bipolar disorder. Sir, age of 3, you make a diagnosis of diabetes. Absolutely no problem. Age of 3, you make a diagnosis of valvular disease. No problem. But there are definite diagnostic laboratory confirmations. This is an arbitrary criteria. It's a bit of problem. Then it is pregnant children in bipolar disorders. I think maybe I'll just run through the quickly run through the case summary. This question is for the medication for the pregnancy. It's going to be a little bit of, can't talk about it. This is one of the reasons why I say that majority of the mood disorders start before the age of 20 years. If you start on so-called prophylactic drug, continue that, especially the patient is a female, marriage and then pregnancy and then breastfeeding, child rearing, all those things are going to be a problem. I think most of you know valproate is, if I'm right, if I'm wrong, please correct me. Please correct me. Like, I don't know if you can correct me. Valproate is how do I see the questions here? Okay. Valproate is banned by European Vigilance Commission for every woman with childbearing age, except for the management of epilepsy. Bipolar disorder, valproate is not allowed. This is, I think it's about 3-4 years, 4-5 years. Prescription of valproic acid is not allowed by the European Vigilance Commission, except for the diagnosis of management of epilepsy, because they categorically mentioned that the evidence for the valproate use in bipolar disorder is not valid, and that is by doing that. What's happening here? Somebody is doing this, right? How do I see the questions? Is there any way?
Sir, you need to stop sharing and then we can see that.
Oh, yeah, right. Okay. Then I'll see that. I'll go back to that. Yeah. Right. And then why sometimes there's confusion, DD, BD and schizophrenia, right, sir, psychotic symptoms, sometimes the history may not be very correct, and those things are fine. Maintenance with mood stabilizer, how long? You want me to give answer in one word? Lifelong. I think last time I told you. Whose life, doctor? Your life or my life? That's what the patient asks. So lifelong. This is what mood prophylaxis is for lifelong. There are no shortcuts. This is what it meets. It's not like it makes sense, but practicality we have to look at. What to do to stabilize the patient of lithium? Oh, right. Oh, it's a great question. If lithium, valproate, carbamazepine, atypical antipsychotics fails, what is the? I think it's a wonderful question. Suppose you give lithium, it didn't work. Valproate, it didn't work. And then carbamazepine, it didn't work. Atypical antipsychotics, it didn't work. Then how do you? Sir, treat the patient, the episodes, acute episodes. Don't worry about the maintenance. You will learn lessons. I'm telling you, this patient, treat the acute episode. Maybe for 6 months continue and then stop it, unless he has got like in every year 2-3 episodes, it's going to be extremely difficult. Average number of episodes in bipolar disorders are 3 to 4 per 10 years. So if it is that, right, which sometime back I used to talk about, maybe people don't like, antibiotic approach in the management of bipolar disorders. Right, let's take some of the questions here, sir. Why is it underused, like lurazidone? Lurazidone, the problem, sir, see, like number one, the dosage for antidepressant, it's like a peculiar drug. On one side, it's an antidepressant. On the other side, it's an antipsychotic. It's a little bit of confusion, right? Number two, it's supposed to be 20 to 40 milligrams. We have only 40 milligram tablets. Second thing is that quite a few people have akathisia. That's it. And then the usefulness, as I told you that, how confident I am not confident. Very true, hypomania is blurrish. Yes, sir. Role of vilazodone. See, like I did try in some patients, but I really cannot talk very clearly about it, because the molecule itself, again, it has its own problems with severe GI symptoms and then diarrhea. But specifically for bipolar depression, is it effective? I don't say that the drug is effective, not as effective as escitalopram. So maybe to a certain extent, I say that you can try it, but definitely. Lifelong prophylaxis, do you support it? I think it's a great question. Theoretically, I have no choice. It's not according to me. Bipolar disorder is a disorder, episodic disorder, recurrences every 10 years, 3 or 4 episodes. And then one of the Ang studies says that till 70, 80s also, it doesn't burn out. There won't be increase in the number of episodes, but it is going to be there. So might as well give. I'll give, provided the drug is preventing the next episodes. If you're convinced that this particular drug is completely preventing the next episode, I have no problem. I'll continue lithium. But is it doing it? That's what the question is. That is what we discussed for one episode of Mania. Why did you continue for 1 decade? Those are the kind of questions. Between lithium and valproate, which mood stabilizer? Sir, again, you are asking a wrong person. Valproate, I stopped prescribing, sir. Chintan must be very, very angry with me, but still I say that, sir, valproate, I stopped prescribing, almost stopped, like, I don't try it because I am not finding it. I don't think that it's going to be. 45-year-old female, valproate toxicity. What do you mean by, sir, valproate toxicity? I don't understand. EPS prone to atypical and non-responder to clozapine, combination of lamotrecin, lithium, what should be the next? So the whole lot of things are little bit of a confusion here. Valproate toxicity, I don't understand. EPS to atypicals. Atypicals definitely produce EPS. Risperidone produces, olanzapine does not, quetiapine may not. Non-responders to clozapine, I don't write to clozapine so early in bipolar disorder at all. Clozapine is very, very late. I hardly have maybe 4 or 5 patients where I'm desperate. Otherwise, I don't. Is lithium mood stabilizer or antimanic or antidepressant? I can say one thing. In a small group of patients, lithium is an effective prophylaxis drug. It is an effective drug for prophylaxis. That's in a small group. What is that group? No, I'm not going to talk. It's not that, elation, none of those things. We do not know which group, but in some small group, I think it does very good job. I leave it at that. Anti-manic effect, I don't know. Antidepressant, again, I'm not very sure about it, but prophylaxis seems to be good. Clobazam, there's no evidence, and then hardly anything. Still see clinicians using fluoxetine in bipolar depression. Does it surprise you? I'm sorry, I will also surprise you. I am also one of them. What to do, sir? Is all SSRIs have same efficacy as you say escitalopram? For many use it. I use it, escitalopram. SSRIs are as good as majority of the cases. Right? Still, imipramine is the gold standard. SSRIs, especially, I talk about fluoxetine, escitalopram, sertraline. Absolutely effective drugs. Fluoxetine, I don't write much because of the drug interactions. Escitalopram and sertraline, I write very, very happily. I can write it to a 5-year-old child. It may not be every indication, but I have the confidence. And 90-year-old man, I can write 2.55 milligrams of escitalopram. 5-year-old child, if there's indication, I can write. That is the confidence I have on escitalopram. I think that's. Yeah, that's right. Regarding patient developed flaps with valproate. Oh my, okay, which Stafford and lithium was started. This is regarding the question where lithium and then valproate, lithium 600, valproate 400. There's some toxicity. I said that I didn't understand. I think the doctor has put it saying that some flaps. Then developed drowsiness, slurring, ataxia with lithium 600. My God. Yeah. Right. See, this is one odd case. With valproate 400, kind of severe tremors like 600 milligrams, severe ataxia and slurring of speech with 600 milligrams of lithium, and that too, blood levels are being on the lower side. Sir, I will tell you one thing. I would suggest you start the patient on olanzapine, provided if this man or woman does not produce too much of a weight. Abnormal weight gain, right, that is again a problem. Otherwise, olanzapine, I feel is that a reasonably good drug. If doesn't produce weight gain, you can try this other than carbamazepine and all things. I think it's good. Some psychiatrists think that why not let patients enjoy their hypomania? No. It's not the question of that. I don't consider that as an abnormality. It's a normal variations which are there. We all keep walking and then there's a sprain. Sprain is a problem. It gives pain. There's no doubt about it. But every sprain, you don't go and take, like go to the orthopedician and then go take rest and do all sort of things. No. We do have the problem. It will go, it takes some minor rest and all things. It will subside. It is something like that. Don't make it like in the big diagnosis and then lifelong treatment, long stabilization. That's where the problem. OFC really, I don't use that much, but this is again something which I don't understand. On one side, the same group which keep telling that don't use antidepressant. On the other side, the same group saying that use it combination of that. All right. How do you go about bipolar depression, which doesn't respond to oral medications, antidepressant, atypical antipsychotics, mood like that? Yes, this is a problem. I understand. Sir, I think it's a very good question. Patient has got a bipolar depression, fairly severe. You give antidepressant, it's not working. You give so-called whatever, lithium valproate, it's not working. Antipsychotic, it's not working. Patient is continuing to be in depression. Here, one thing I say, I know depression is painful, with significant disability. But there are 2 points here. Number one, please see that patient does not do anything adventurous like attempting suicide. Repeatedly tell the relatives suicide list 24/7, please take care of the patient. Number one. Number two, I try anything, but I'll tell the patient relative one thing and tell the patient also one thing. Look, ma, you're going to be all right. When give me some time. You're going to be all right. That kind of a thing. I'm not trying to sort of tell them like an irrational things or like an bipolar depression has to recover. But the thing is that within that period, the suffering, morbidity, and then suicidal risk is very, very significant. That's what you have to. But it's not like MDD with dysthymia, chronic depression. Bipolar depression has to recover. So give that confidence. Give them saying that you are going to recover. Your wife is going to recover, but take care of that now. Like she doesn't attempt suicide. Meanwhile, I'll try what are all the things I can. I'm trying all the methods. Definitely, I'll try. Here, I'll try everything, every combination also I'll try, provided I don't produce side effects. That's the kind of thing. What is something which I'll do. Gold standard for bipolar mania monotherapy. Sir, last time I did treat a patient for bipolar mania, first episode inpatient, only with risperidone. And then in spite of some of you accusing me, I still stuck to that, saying that I treat with only single drug. Drug of choice for mania and depression, pregnancy and lactation. That's going to be, pregnancy is going to be on one side a big problem. Suppose I'm forced to. Suppose I'm forced to treat a patient with mania in pregnancy. I'll go for olanzapine. Category C, and then I'll reasonably go for that. And then if you say that, I can go for this one, depression, I'll go for escitalopram. I obviously no valproate, no carbamazepines. Lithium again is a problem with lithium, sir. Literature-wise, Epstein anomaly, that's not, I understand. It's a very point, like in 0.8%, 8%. I'm not bothered about that, but I'm worried that even in the adult patient, the fluctuating blood levels, I'm very much worried. The same lithium getting, passed onto the fetal stream. I do not know, so I'll be a little bit cautious about. Anyway, lactation, they said that no, don't give. One of the drugs contraindicated. So olanzapine I give, escitalopram I give. These are all forced choices. I don't have a choice, but now, like if it is, I'm forced. I can't say that I won't treat. I'll go for it. Then somebody may say that ECT can give it. Fine, you can always do that. But when it comes to the drugs, right? ECT always. See, one of the reasons why we don't find so much of resistant depression is because we give ECT very, very frequently. Great question is coming here. What about patients of BD with OCPD having current depression, patients on risperidone, quetiapine, clonazepam recovered partially but having phobic anxiety? I don't know if you like my answer. I'll say go ahead and start escitalopram. This is one thing. One of the reasons is that OCD, OCPD is not uncommon as a comorbid, as a premorbid personality in bipolar disorder, which responds very well with SSRIs. If you don't give SSRIs, it's going to be a big problem. Sometimes irritability could be because of the premorbid personality. So that's one of the reasons why I say that. If you say no to antidepressants, how do I treat? Lots of studies show that bipolar disorder comorbidities, Kessler study says that almost 90%. And most of them are anxiety disorders and then OCD. How do I treat? Somebody says CBT. Sir, I don't know CBT. I can't give CBT. How many sessions of CBT? How much the patients can afford? Each session 2,000 rupees? So 10 sessions? Where will they come from? How do they come from? So many sessions. I give a simple escitalopram. They do well. That's exactly what I do. That's a kind of a thing. So let me, I think it's unfair. I have to go back to the questions now, like how long, like when everything failed, right? As I told you, that more of an antibiotic approach. Duration of treatment, it's very difficult to say that. Generally it is, they say that it is lifelong. It's something like that. But if one of you argues saying that I will suppose the episodes are, let's look at a hypothetical situation, not just hypothetical situation, textbook description, 3 to 4 episodes, 10 years. Each episode maximum period is about 7 to 8 months. I treat the episode. 2 years, I keep the patient totally free of medication, provided he doesn't keep having more episodes. I am with you. This is totally going against the philosophy of prophylaxis and mood stabilization, but it depends on different patients and then different kind of episodes, which is important. Yeah, I think what is the role of yoga, meditation, acute phase, sir? Mania, definitely. Who is going to do yoga and meditation? Acute phase, out of question. Depression, they can't concentrate. But as I told that, like hypertension, like diabetes, your lifestyle changes definitely will have some, like some mild effect on controlling that. But how much dose can be reduced, I do not know. I really cannot. Replace the need of mood stabilizer, out of question, sir. Out of question. I don't think, at least personally, I don't think. Management changes in bipolar 1 and 2, that's exactly almost. CanMat says that like most of the data for bipolar 2 is extrapolated from bipolar 1. It's not there. I think early pregnancy, I did talk about it. Okay, olanzapine seems to be a better choice. Bipolar with ADHD. Tell you frankly, I don't have experience. I don't diagnose adult ADHD. A pediatric childhood ADHD, later becoming a bipolar, I treat bipolar. But this seems to be, adult ADHD seems to be a very, very frequent diagnosis in the Western. A lot of people are in high dose of amphetamine and then methylphenidate. My experiences, I'm a little bit scared also. Unmasking of BPD in depressed patients, very, very, very good question. I think last 2-3 times I said that this has been created a kind of lot of anxiety and fear in all the psychiatrists, saying that, my God, every depression can be a bipolar later. So I am being cautious. Too much of caution is also not good, sir. Please treat your depression. When it comes to that, we'll treat. What's the problem? We can very effectively treat mania. Mania, excellent. How many, see, maybe here, let me ask one question. One question there. How many of you, the chronic mania, lasting for more than 6 months? What percentage of your patients have chronic mania lasting for more than 6 months? And this BD is a good prognosis. Maybe I'll just come to it. I think I have another 10-15 minutes of time. I'll just run through some of the slides, what I have. More on BD, good prognosis, and then BD is a myth. I think I did talk about it. 70-year-old lady, let me run through this, sir. Yes, I know rapid cycling, it's definitely, it's not going to be easy to give antidepressant, but rapid cycling concept itself is something which we have to be very, very careful. I think we have just about another 15 minutes. I'll just quickly, yeah. And here, suppose there is a question. You have been repeatedly talking about the prophylactic drugs are not very effective. I found them, it's not that useful. But for lithium, other drugs are not doing effect. But for this, you're not doing effect. Well, no, like you're talking, no, like in the whole lot of textbooks say that, journals say that, everything says that, but you seem to be talking slightly differently. This is purely from my clinical experience. I think last time I showed how I collect the data. Here, I just quickly run through one of my patients, this young boy who is about 22 years when he came to me in 2008. This boy is with me till last I saw him on 2019 October. He's euthymic. I think usually he comes once in 4-5 months from Karnataka, and then now because of the COVID, he's not coming. Look at it. Very quickly, I'll run through. We don't have much time. This is the first episode, Mania BD1. He came to me. By the time he came to me, he was on this medication. Somebody was cheating, trifluoperson. This, right? Family history is not there, right? He had a psychotic, yeah, paranoid symptoms. Fine. Like very, very quickly, I'll go through. I don't think we have much time. Maybe this case, if somebody is interested, we can take up later. 2008, improvement 90%. Then I stopped valproate and kept him only on quetiapine. On quetiapine, he had a depression, 2008. And then he had a mania, 2009. Once he had mania, I thought enough is enough. And then I started him on lithium and quetiapine. Lithium is 900 and 600. I think it's a good dose, sir. I keep doing the serum levels regularly. So he has recovered, improved, right? 90% is recovery. This is GAF. This is the drug. This is the dosage. This is the follow-up date, right? 2009 March, and then right, he remained, he improved, and then continued to improvement. 2010 November. Then he had relapse of mania. Sir, he had relapse of mania while on 2 drugs, lithium, good dose of 900 and quetiapine. He had depression here while on quetiapine 300, which is the prescribed dose. He had a relapse of mania while on quetiapine 300. While on quetiapine single drug, he had one episode of depression, one episode of mania. One of the excellent complaints, because his sister is medical professional. Excellent complaints. So 2 episodes here, right? Come here. Okay, even after relapse of mania, I admitted him, again treated him, risperidone, quetiapine, and while on this lithium, he again had depression, right? Then within 6 months, he again had mania, right? While on lithium, one mania, one depression, one more mania. While on lithium, plus other drugs, quetiapine, olanzapine, and then he has a doubtful depression. Then again, one more depression. 2 or 3 depressions episodes, 2 manic episodes while on therapeutic doses of lithium this boy had. But every time, within a short period, he used to recover and all. But this episode, 2016 April, what he had was such a severe mania. I just don't know why it happened like that. It went almost more than 8 months or 9 months. This is haloperidol. You see, this is the first time I'm starting in the last 8 years. First time I'm starting, he was on this, started by somebody, and then starting on a typical antipsychotics, haloperidol, trifluperson, because I was not able to manage 8 ECTs. Still he was like that. Still can see the ridiculous lithium, haloperidol, trifluperson, lurasidone, lithium and haloperidol. I don't combine these two at all because I'm always worried about some neuropsychiatric irreversible complications. But still here, I couldn't help it. All these drugs, it took. See, it almost took 1 year, 2016, April to 2017, March, I came to 90%. When this 90%, that time he was on lithium 900, lurasidone 80, and trifluperson 15, haloperidol all slowly have reduced. So I don't really understand why this particular episode took 1 year, why all these episodes for a brief period. And while on lithium, all along, from 2009 to 2017 till today, he is on lithium. 11 years on lithium with a reasonably good therapeutic levels. This is the number of episodes he had. He had depression, mania, depression, mania, depression, severe mania. Do you want me to continue lithium for this patient? Right. All of you say that start valproate, start this, start carbamazepine, start something. No, I know that there, because when I presented this, so many, but what do? Suppose I show this like a case history to a non-psychiatric medical colleague who doesn't really much bother about it. At this point, I tell him that no, lithium is a good drug. This should be quetiapine, no latest drugs for the profile. At this point, he'll ask me, hey, what's wrong with you? 8 years, 7 years, you have been giving him these drugs, and he has been relapsing. You don't have anything. Why are you continuing this medicine? How long do you want to continue? Are you using any kind of a therapeutic discussion, analysis there? Am I right? But I don't have a choice. Right. This is the last I have recorded. Now, after this, I went in slowly. I started reducing lurasidone, all the medicines are out. Last visit was in 2019, October. The boy was doing completely 90%, only on lithium 800. Do I say is it because of lithium effect or quetiapine effect or haloperidol effect, or is the natural course? I do not know. Maybe some other time we can discuss about this case also. We'll see that, right? I think I have a few more minutes. Right. Somebody asked about the good prognosis. I think, I just want to run through. Antiniroluman, it's first time, 10 days history, acute episode, hyperactivity, elated mood, grandiose, diagnosis, mania, bipolar disorder. Right, sir? There's no doubt? Right. I have made a psychiatric diagnosis here. Adult psychiatry. Then prognosis. Please, I'm not trying to say that this is not there, that is not there. Child psychiatry, entire child psychiatry, is there any specific disorder where we can talk about recover? Geriatric, mostly dementia. Some of the mood disorders you leave it. Adjustment disorders, minor problems. Major disorders in geriatric psychiatry, is there anything where you can say that patient recovered, symptomatic recovered? No. Adult psychiatry, bipolar disorder, mood disorder is one thing where we can talk about a specific recovery symptomatic recovery, sustained euthymia for umpteen number of months and years. If that is the kind of a picture, I don't know why people keep talking about functional recovery is not there. It's a chronic illness. It's a whole lot of things. I know glass is half full, half empty. We always have to look at half empty. Are we trying to do something? Look at the other side also. This particular patient, father comes and asks me, am I wrong? Am I giving a false assurance here? 99% your daughter is going to become all right. 4 to 6 weeks, reasonably. At the most, maybe 8, 12 weeks. Can she continue? Definitely. After that, I'll stop. Yes, recurrence. When? I don't know. Nobody knows. And then do you have any drug which can completely prevent my child's next episode? I'll give it a try. Beyond that, I can't say. Sir, Chintan, can we take a few more minutes?
Yeah, sir. Sure, sir.
Yeah, right. See, this is just to show you, I was talking about it. How this point of irritability and then rapid, ultra-dian cycling, anything is possible in bipolar disorder can get to the diagnosis. Sir, maybe I suggest you to quickly run through that. This I have taken from a textbook, 2009, 80-year-old girl. Parents are divorced. The child does not live with biological parents. Last seen her father 2.5 years back. I'll put this here. Right. Periods of explosive irritability. Rage, 80-year-old girl. Three times per week and can last a few minutes to an hour. Sir, please note. The episodes are 3 times per week and last for a few minutes to an hour. Diagnosis of mania does not come, at least 7 days should be there. Fine. Grumpy moods. Since she was 2 years old. Very sad mood. This again lasts for about 20 minutes. Sometimes maybe a day. Average is about half a day. So the sad episodes are about half a day. The irritable episodes are a few minutes to few hours. Mood swings. Depressed mood, my goodness. It's a sad. Manic episodes. Where are these manic episodes? Except that a child throwing temper tantrums when your parents are divorced, you don't live with the biological father and then you live with stepfather and then step sips. Confidently make a diagnosis of bipolar disorder. Where are we going? And then the statement, 1 year mania recovery is 37%. Daily cycling, this is what they talk about, ultra-dian cycling. Sir, how many of you agree with the diagnosis of bipolar disorder in this particular child who is 8 years old and the mother says that from the age of 2 years, last 6 years, she has been going through mood swings episodes. The so-called irritability lasts for a few minutes to few hours and then sadness lasts at the most half a day. And then with the evidence what it is there, we can fairly confidently make a diagnosis of bipolar disorder unspecified. How many of you are satisfied with this diagnosis of it? This is from the textbook example, sir. Textbooks are teaching me this is how children present with the bipolar disorder. This is how you have to diagnose pediatric bipolar disorder. You can post your questions or comments or anything to me. Chintan will give my mail ID or not like him. Put it. I have no problem. I think there seem to be more than about 150 people here. How many of you agree with that? And then this is what I was talking about. This child you diagnose as a childhood bipolar disorder and then treat with what? And how long? Somebody asked, how long, doctor? That is what my problem is. That is what the thing is, why I'm talking about this is that I think this is not fair. And sir, this is not fair. And if this kind of things we do without any diagnostic confirmation biomarkers, I think the reputation of psychiatry as a specialty, I'm sorry, I'm stretching it a little bit too much, among our medical colleagues, no, it's not at all respectable, sir. It's not at all respectable. And the way we change the diagnosis and all, anyway, I'll come to it a bit later. We need to build psychiatry as a good scientific medical specialty and respect among other non-psychiatric medical colleagues. That is the most important thing, because lots of things are going like this. This is not acceptable. Why are we doing this? Why can't we wait? Why can't we hold on to something for some time till we see the reasonable, either a biomarker or hold? Treat the patient acutely. Don't talk about mood stabilization, invariant use of mood stabilizer for lifelong. Come on. Whatever you say, textbooks cannot say that. That's what my point is, cannot say that. Anyway, I'll come back to that. This is another great slide, which, like mind-boggling. I just never, even now, I don't understand. See, I have a limited knowledge. But now sometimes, bipolar disorder, bipolar mania, for me, at the most maximum, it lasts for about 6, 7 months, 7, 8 months. Just now I asked you, what is the chronic mania? How many of what percentage? Here you see, duration of the episode, 4 universities. Duration of the episodes is, sir, this is years, not months. 3.5 years, 2.7 years, 3.3. Is it bipolar disorder, episodic disorder, or are they talking about some other disorder? If they're talking about some other disorder, they should recommend DSM-5 to give separate diagnostic criteria for childhood bipolar disorder. And we accept it. What is this? Duration of episode. I'll leave it to you. And mean age, look at this. A 10-year-old child, this is the duration. And the treatment is? Obviously, the damage, what it is doing is, in the last 2 decades, what is the prescription pattern? Lithium is the gold standard. I keep talking, everybody keeps talking, every textbook, every journal, every latest paper keeps talking about, but clinicians are not writing lithium. Last 20 years, I'm not writing lithium. For reason why? Well, anyway, it's not about this. Antipsychotic mood stabilizer, 20 years. Antipsychotic prescriptions increased. SGAs, obviously, very understandable. None of us are writing haloperidol and trifluopercin, but this is one. But mood stabilizer prescription decreased from 62 to 26. And then primarily by a decrease of use of non-lithium mood stabilizers, valproate and carbamazepine, from 35 to 5. Why? Why is the clinician not writing it? Because clinician respects evidence-based medicine. He looks at them for guidance. He looks at them for protocols, algorithms. But when it doesn't gel with his clinical practice, like what happened to that patient where I said that after 9 years of continuous use of lithium, he is relapsing again and again, recurrence of this mania. I will have my own way, but sometimes I don't have ways also. That is a big problem here. But this is what the fact is. I just thought that I'll show, yeah, right. This is the last slide, sir. Important. That's why BD2, we have to be careful. Diagnosis is prognosis. Diagnosis indicates therapeutics. This is very, very important. I talked about, right. Here, one thing, maybe I don't think I'm going to touch it today. These are very, very important. This is something which is, I think, only peculiar to psychiatry, maybe. Continuation phase. You treat a patient with acute mania. You treat the patient with 20 milligrams of olanzapine. Good. Everything is good. He recovered in the hospital. He's stable. But once he goes back, you need to continue medicine. The same drug, same patient, during the acute phase, He does not experience any sedation. Later, he keeps talking about, I'm feeling extremely drowsy, doctor, the same dosage, and then you keep on decreasing. You don't know what dosage. Same thing happens with risperidone. Same thing happens. There is something peculiar with this. I think sometime later we'll talk about it. And then this is, anyway, I talked about. I think we all have some responsibility. We do the responsibility. Okay, right. Anyway, there are some people who role of depots in psychotic mania, right? Now, like depots, we cannot dose titrate, as I told that whether it's psychotic or non-psychotic, we can give, but how long it's going to be the question, maybe sometime later. As and today, the evidence for long-acting, now like atypical antipsychotics in the management of acute mania is not that, now like in solid. That's one of the recent papers say that. Okay, yeah. DMDD, right? DMDD, even though as on today the concept, there are a lot of loose ends. I think once again, thanks to DSM-5 authors, they have introduced DMDD so that the diagnosis of bipolar disorder in children, the rampancy becomes slightly better, less. But again, it has got its own problem. It takes some time. Quetiapine monotherapy in bipolar depression, I do not see, like, I do try, sir, but I don't have the confidence because 1, 2, 3. Number one, the optimal dose is supposed to be 300 milligrams. 300 milligrams produce lots of drowsiness. Number one, drowsiness, patients throw the medicines out. That's a problem. At the end of 300 milligrams, whether it is going to be effective or not, I'm not very sure about it. Then, what is the suicide prevention potential of efficacy of a quetiapine? I'm not very sure about it. So I do write, but there's a little bit of a question mark. But the thing is that quetiapine is one molecule. Actually, I think all this discussion, all the things are absolute waste. No point. One of my postgraduate asked me, why are you discussing all these things, doctor? Sir, there's one molecule, great molecule. What? Quetiapine. Quetiapine is effective in acute mania. Quetiapine is effective in acute depression. Quetiapine is effective in the maintenance prophylaxis. Why do you want all these drugs and all those things? Yeah, I think he has got a point also, but I do not know how far it's going to be useful in the monotherapy, but we do try. One thing is that EPS is very less, but some issues with the QTC. As a prophylaxis, quetiapine as a prophylaxis, I say that as prophylaxis, you need to be cautious. There's no hurry to start on day one. That is a rule. I think don't follow, please, I'm sorry. Please don't follow the algorithm saying that start on day one, forget it. If the patient is having a recurrent episodes, if the episodes are severe, if you feel that definitely the next episode is going to be very soon, very severe, suicidal or acute manic excitement, then seriously consider prophylaxis. Give lithium a first try and then maintain that. Then other drugs. Otherwise, maybe my favorite is again olanzapine. I do give. We have been trying only olanzapine as prophylaxis in a few patients. Some of the patients it's working. But again, one of you may say that it's a natural course. That is the beauty of bipolar disorder, is that we do not know what is exactly the, like a natural course of it. Combining valproate and lithium. Yeah, right. See, like that's where last time I showed that there's one slide, 7 drugs are used as for effective prophylaxis. Right. It's preferably monotherapy. Otherwise, sometimes, like when you have problems. Right. Let me, I think it was the last slide, but I just wanted to show you. Yeah. No. Yeah. Just few of you who are there still, who still have the patience and who are not very hungry. This is bipolar 1, no doubt. This can be one picture. This is bipolar 1. 1, 2, 3 depressions. This one. See, the gap is so much here, here, here. This is some perfectly. nobody on this earth, planet Earth, can say that this cannot be the picture of presentation of bipolar disorder. Bipolar disorder can present in any which way you can take your pen and then draw. This can be. We have seen this. Only manias, enough. Madam, somebody asked me, hypomania. Only hypomanias. It is not bipolar 2. It has to have a depression. Only manias, it is perfectly bipolar 1. Right? This is bipolar 1. This can be. Management of this, for a long time, we were asking, why do you people say that there's no need to be establishing an episode of depressive episode in bipolar 1? We were all asked to shut up our mouth because they said that depression definitely would have been there. You would have missed the depressive episode. Patient would not have told you about the depressive episode. So one episode of mania is enough. Depression is immaterial. So we all shut our mouths. But the questions keep coming up. We can, externally we may not. Today, Jules Angst published a paper saying that there is something like a unipolar mania. It was such a music to my ears. This he calls unipolar mania. There are so much of advantages when you have unipolar mania. Absolutely. The concept has to pick up. Right. This is bipolar presentation. This can be. This can be another bipolar presentation. This is a nightmare. MDD, RDD. I've been treating with escitalopram, so much of gap. Here also I treated with escitalopram. Here it developed mania. He went to my neighbor psychiatrist and he said that what the hell MS Reddy is doing. All years he has been treating bipolar disorder as recurrent depressive disorder. He has been treating with antidepressants, which are nonsensical drugs, which are not at all now advocated in the algorithms. And maybe possibly you would have had a mania also, you would have missed finish time. So some of us, what they're doing is that even here, this is where the spectrum comes after 3. And then here we are starting with all those, whatever the drugs. Instead of antidepressant, we are treating them with this. And then we say that antidepressants are not effective. Right, that's another story. Let's not. This again, this could be the so-called rapid cycling kind of a pattern. Switch, depression, mania, depression, mania, depression. This can be. All this can be presentations of bipolar disorder. Right, that's it. So I think that is how it can be. Yeah. Somebody very kind to, Dr. Minaj, I think you are very kind to summarize some of the things. But I think last time somebody asked me a question. You are talking, Dr. MS Reddy, all those things. If I don't start a mood stabilizer to my patient when they diagnose mania, my professor will scold me. So don't quote MS Reddy has told this like that, but no, like some other take-home points will be definitely we have to be extremely cautious about diagnosis of bipolar disorder. I would say rather underdiagnosed to start with. We don't lose anything if we wait for the next classical episode of mania to emerge. Forget about all those molecular scalds and neurobiological damage and all things. No, sir, nothing is going to happen. You can wait. You do a lot of service to the patient. Do no harm. You're going to do a lot of service. Then once it is required, go ahead. But when you say go ahead, when I say, also look at what are the side effects which the patient is having. I talked about significant side effects, not serious side effects. For example, I'm on lithium. Today I have to give a presentation. I've been going on wavering my hands like this. Suppose I'm in lithium and then my hands are showing fine tremors like this. So what do? Before presentation, I'll stop it. My tremors will disappear. This is how patients do that. So we need to take care of this also. These are significant side effects. Sedation, EPS, subsyndromal EPS, cognitive dullinger's side effects which we have to be aware of. Otherwise, that is a main block for functional recovery. That's what say that. Lithium, yes, but right. I don't want to end now like in today's topic on a rather pessimistic or negativistic, but only thing is be careful. This is a lifelong thing. Be careful. Don't have to worry so much about it. Patient is with you. You can, the most positive thing is anytime, sir, first, second, 10th, 20th, 30th episode, I am exaggerating, of mania, patient has come to me, it's 25th episode of mania, and he'll ask me, doctor, do I recover? I'll say, yes, you recover. Will I become completely all right? Yes, you'll become completely all right, provided you don't have any other physical comorbidities and all those things. I don't know. That is the beauty of bipolar disorder. Bipolar mania has to recover. Bipolar depression has to recover. That's it. Otherwise, maybe my diagnosis is something going somewhere. Only thing is, I should see that their morbidity is minimized. They don't attempt suicides. Absolutely, that's the biggest risk. That's what I showed the Thomas Incells. After 30 years, we just didn't do anything in controlling the suicidal risk. What are we doing? That's the thing. Otherwise, the advantage is give that positive thing to the patient. Look, ma, you are going to be all right. I'm going to make you all right. It's not this thing. It's a natural course of the illness. I'm with you. I'm with you. Your mania is going to completely recover. I'll see that. Your depression is going to completely recover. How much of a positive feeling this is going to give to somebody who is down in the depression. And I'm not lying. And I'm not telling them no false reassurances. I'm speaking the truth. And I mean it. That is what is good prognosis. I think one of the doctors asked me, doctor, talk about good prognosis. 100 years back, somebody said that these are good prognosis and continuous and episodic disorders. I don't know what happened. Now we have to reinvent. Sir, next time whoever comes, I'm going to get one of the recent papers where I've seen, I felt sad. The paper starts, one of the recent papers, 2017, bipolar major depressive disorder is people think that it's an episodic good prognosis disorder, but it doesn't look like that because of this. He talks about it and then prepares the paper like that, and then I'll show you the whole paper and then what are the results. Why we psychiatrists sometimes seem to be very much against our branch of psychiatry, trying to prove that all psychiatric disorders are chronic and then you have to take medicines lifelong and you have to be there, you do a lot of psychosocial interventions and then you do what's wrong? Why do you have to, at the end of 6 months, if major depressive disorder, the patient is all right, recovered, why do you have to say that after 10 years he's going to have a second episode? That's why it's not, we can't say that it's a good prognosis. It's like saying that sinusitis is a bad prognosis because every year like in a monsoon season, he gets sinusitis. It's bad. What are we? No, I think we have to, somewhere I think we need to sit and look back. Why? Schizophrenia, nobody says that it's a good prognosis. Autistic spectrum disorders, nobody says. Dementia, nobody says. But when it is there, no, there's no functional recovery. There's no. Your job as a medical doctor is to give them symptomatic recovery. After you remove the symptoms, after you get them out of the symptoms, it is his job to take care of his functional this thing. Why are you and me worried about this, sir? That's it. Thank you very much. Bipolar disorder, mood disorder is a little bit of a more of passionate subject for me. And you see that the data, every time I look at the data, what to do. And I think, thank you all. I should thank you all for giving me this platform and then getting me talk about some of what I call is loud thinking. You don't have to agree with me. Sir, please don't, because I didn't agree with many people. You don't have to agree with me. But take this point. Why the hell this man told bipolar 2 disorder is a myth? Why the hell this man told that we are overdiagnosing bipolar? That's it. I think we are all brilliant people. You are all intelligent people there. So, thank you very much. Thanks. We'll meet again next week. Right. Case series continue. That's the only thing I have. Maybe a few more cases I have. I'll definitely come back and share with you how much of damage I'm doing with the kind of diagnostic queries also I'm going to share with you. Last time also I shared with you, I'm going to share with you. Thank you very much. Thank you all. Good night.